All right. I think we are live here. So there's a lot going on in the world and specific to Medicare. So let's talk about some of the big things happening in Medicare. I'm going to go over three in this video, and then I'm always open for your questions and comments. Welcome. Thanks for being here. So there's a lot going on in the Medicare space, but I'm going to go over kind of the three big things that I think have the biggest impact on those of you who are watching. So again, there's more than this happening, but the three big ones. Let's talk about the big bill that is currently with the Senate. It is not looking like it's going to pass as is, so there will be changes to this. So I don't really want to speculate too much on what's going on here, but the thing that I do want to address on this bill is a lot of the headlines are talking about the $500 billion that would be cut from Medicare or could potentially be cut from Medicare because of this bill. So I just kind of want to go through that mechanism of what that means. And again, this isn't passed. It hasn't happened yet. There are going to be changes, but the function of that, because nowhere in this bill does it talk about cuts to Medicare. So there is nothing in here that says, hey, we're going to cut $500 billion from Medicare and then that structure of it. So what's going on here is that every time a bill is introduced, there is the Congressional Budget Office, and people can send in, meaning congressmen and women can send in, hey, there's this huge 1,000+ page bill. How is this going to affect certain things financially? And then the CBO will come back and say, hey, here are the impacts of this bill. And so right now with this bill, it is scheduled to increase deficits by about $2.3 trillion over 10 years. And so they sent in to the CBO, hey, how is this going to affect things like Medicare? And within that, I'll actually share, you can go and read this for yourself. Here's the CBO's report on it. Member Boyle was the one who submitted this. So would this enactment of the legislation that increases the deficit trigger sequestration? Now, sequestration, we need to define that a little bit. That is a mechanism where automatic reductions in certain spending categories are going to happen. And so with that, it says, yes, in according with SPAYGO, the Statutory Pay-As-You-Go Act. This was back in 2010 that this was enacted. So in accordance with this, if there is a bill that is going to add to the deficit, then that could trigger reductions in spending in certain cuts. So that's basically what's happening with this inquiry, because this bill is projected to have $230 billion in deficits in the first fiscal year of 2026. So then the subsequent question, and as it relates to us, is how would this affect Medicare and other programs? With sequestration, there are certain programs that are protected from these budget cuts. So things like Social Security is an example. There are other low-income programs like Medicaid and SNAP, but Medicare is not exempt. However, with Medicare, it is a limit. It can't exceed 4%. So it can't exceed 4% a year. And in that case, that's coming to that estimated $45 billion in potential cuts for Medicare. And then $185 billion would have to be found or sequestered from the federal budget from somewhere else. So that is where this number of the $500 billion is coming from over 10 years. That would come out to $490 billion if we wanted to really get specific about that. And then this is if Congress does nothing. So if nothing changes, not only in the bill, but in future measures, they could enact things that would offset this deficit. Hello, it's me, Ann Clinton. Thank you for being here. So again, these projections are if nothing happens, and then Congress does have the power to override these cuts or find ways to cut spending elsewhere that would prevent these. So this is a political game of sorts for you. This has happened again this happened with Reagan, George H.W. Bush, George W. Bush. This happened during Obama's term. Sequestration threats have happened with Biden, and now it's happening with this big bill. So it's kind of these ticking time bombs where they put in these things into the bill saying if we don't, or if we do have this deficit, we're going to cut from somewhere else. And then in the future, it causes a big fight over things as well, saying, look, if you don't agree to what we're proposing here, then that means that you don't care about seniors or anything else because it's going to have these cuts. So just a heads up on this game. Again, this hasn't happened yet. There's another kind of ticking time bomb in 2035 with Social Security, but again, we'll be on top of that and see what's coming. So again, those of you, that's the big bill thing real quick, again, because it's all speculative. I can't really talk too much about what that impact will be. If there are cuts to Medicare, the way that you would experience things like this personally, again, they're not going to come in and rip money out of your hands exactly, because the way that you would experience this would be something like increased Medicare premiums. So that is something where you would feel that, right? Like if they increased your premiums, increasing deductibles, increasing copays on the Medicare side of things. The big heavy brunt of this could be felt by providers. That means that they could lower payments to doctors, hospitals, and other areas where Medicare payments are going out. Providers have kind of taken a big hit over the last 25 years with this. There's this graph where it shows that inflation since 1998 is up about 82%. And then Medicare physician payments, at least what they use to calculate them, is down 9.9% over that time. So physicians who are seeing Medicare patients are seeing a cut in pay. And so those on Medicare would feel these cuts in the sense of, and this is before this bill, but physicians more and more are choosing not to participate with Medicare because the reimbursements are so low. And so that would affect the availability of these providers. And then again, if there are fewer providers who are available to see Medicare beneficiaries, then that turns into an access of care problem. If you're going with those, that now we're talking with those participating with Medicare, if they're on something like an Advantage plan and they aren't getting paid enough through those Advantage plan networks as well, they're dropping from networks. So there's this constant negotiation of doctors who are, we're not getting paid enough to see Medicare patients. Let's spend more time seeing non-Medicare patients so that we can get reimbursed more through things like employer group coverage or private pay or whatever else that might be. So these downstream effects of Medicare budget cuts, again, aren't necessarily them coming and taking money from you directly. It's more of these indirect approaches. And then for those kind of lower income individuals who are relying on things like Medicaid, again, the access to care is something that could potentially be an issue here. And then with those budget cuts through the funding for Medicare Advantage programs, that could also be something as well. So if you are on a Medicare Advantage plan, the reimbursements back to those insurance companies could affect your budgets or at least your benefits, with things like your maximum out of pocket potentially going up. If you don't have a deductible, it might be introduced. They could cut the extra perks, things like dental, vision, hearing, those over the counter benefits. So there's just different levers that they can pull in terms of trying to figure out where these dollars would come from if these budgets are cut. So just an idea there. All right, let's move off of that from the big bill, and let's move over to the Medicare Advantage audits. So Medicare Advantage is a very hot topic in the world. And so one of the things with that is these audits that people have been requesting for a long time to make sure that the insurance companies are doing what they say they're going to do. Let me show you this real quick here. This was the announcement on the CMS.gov newsroom. There's this aggressive audit strategy to audit these Medicare Advantage plans and the insurance companies that are doing them. Here's the thing that really stood out to me. So CMS is several years behind here. And the last time that they had a significant recovery of Medicare Advantage overpayments occurred following the audit of the payment year 2007. So they are dramatically behind on these audits. Now, again, the government is approximating or estimating that it's 17 billion annually that they're doing as overpayments. And then MedPAC is saying it could be as high as 43 billion. So in terms of finding some dollars, would it be great if we could find some dollars there? Yes, I love it. I love the idea of reducing overpayments. I love the idea of reducing fraud. So that's something to keep an eye on. One of the things to understand of how to do that is there are going to be costs to do this. And I talked about this on another video. If we're trying to reduce fraud down to zero, sometimes the ability to do that, or what has to be put into place to reduce things down to zero, is more expensive and more costly than allowing some of it to go through. It's not me advocating to allow fraud. It's just the idea of what does that look like to implement. And so in this case, you look at the workforce expansion. So I'm going from 40 to approximately 2,000 people. So it involves hiring more people. There's going to be a cost to offsetting what is ultimately hopefully found in audits of repayment. So just something to consider there. But just know that this is going on. They're hoping that by they'd like to complete 2018 to 2024 audits as soon as possible, and then be current every year after that. So that is something that I think is a admirable goal. If I remove the parties out of this, like I don't care if it's a Republican or a Democrat here, just making sure that we're auditing the insurance companies that have made these agreements with the government to provide these benefits in a certain way. Let's make sure that they're doing that. I have a great question here. Has any HSA investment changes? Crypto King Eddie, any HSA investment changes? If this is going back to the bill, the way that it is proposed, there are some fantastic, in my opinion, HSA changes that would be included in this bill. Again, separating parties out of this. It's the idea that I love HSAs. I have several videos on HSAs on this channel and the power of these HSAs. So they are essentially proposing to double the contribution limit. And then what I find great from a Medicare perspective, which is what I focus on, is it would allow a few things from the Medicare side. So first, as it sits currently with an HSA, if you are enrolled in any part of Medicare, so Part A only or Part A and Part B, you're no longer allowed to contribute to an HSA. You have to stop your HSA contributions. What this is proposing is that if somebody does qualify for Part A and they choose to get Part A, but they postpone Part B because they're currently working and they're covered by an employer plan, then you could still continue to make HSA contributions when you have Medicare Part A, which in my mind just makes sense. It's just something that I think would help alleviate a lot of the confusion. A lot of seniors ask me, hey, should I get Part A only, even though I'm staying on my employer plan because it's free to me? And the question is always, well, do you have an HSA? Because if you have an HSA and you want to contribute to that, or you have an employer contributing to that, if you get Part A only, you have to stop those contributions, and so does your employer. So the idea that that wouldn't have to be a problem anymore, I think, is appealing. The other thing from a senior's perspective is the catch-up contribution. So in this bill, it's proposed to allow both spouses to contribute their catch-up contributions to the same HSA. So to understand what that means, currently as it sits, so for those who are 55 years and older, if you want to make a catch-up contribution, you can, which is an extra $1,000 a year to your HSA. The trouble is that you have to have your own HSA to make those contributions. So let's, for example, say that I am currently working, my wife is not working, we're both covered by my health insurance plan through my employer, and then I have the HSA. HSAs are individual accounts. So my HSA is not my wife's as well. It's not a joint account, it's my HSA. So I would be able to make a contribution, that $1,000 catch-up contribution to my HSA, but my wife could not make her catch-up contribution to my HSA as it sits currently. She would have to open her own HSA in her own name, and then she could make that catch-up contribution because she is covered under a high deductible health plan through me, but they have to have the separate HSA account. So one of the proposals here is to allow it to just, it all goes to the same one, because I would say most people, most couples, really are just leveraging that one HSA through the employer group where the employer is contributing to it, and we just have the one. That's how I'm set up with my wife. We just have the one. So it just makes things a little bit easier there. So that's a great question on the HSA investment changes. There are more. So things like they are adding, again, this hasn't gone through, but one of the proposals is that you could have gym memberships and sports and fitness equipment that would be considered HSA eligible expenses. There's a limit on this. So $500 for an individual, $1,000 for a couple filing jointly. So you can't just go buy a $25,000 home gym and just use your HSA for all of that. But the idea that you can, it's expanding what is considered HSA eligible from that perspective. Great question there. And yes, there are there are income limits on that. So you do phase out on the higher contributions and everything else. There's a phase out of that for those with higher incomes. All right, so we've covered two, the big bill, we covered the Medicare Advantage audits, we went back to the HSA implications of that big bill, and now let's talk about the Medicare supplement plan increases. I'm sure if you haven't seen anything about this, you will, or you're hearing about it now, but there have been major Medicare supplement plan increases across the country and more targeted to specific pockets and states where it's quite dramatic. So we're seeing 20, 30, 40, I saw a 51% increase on these Medicare supplement plans in certain areas. And so the question is, why is this going on? And then what do we do about this? So why it's going on from 2023 to 2024, we saw higher than normal increases. So the average was, it's 9.9%. I'm going to call it 10%. So the average was a 10% increase for Medicare supplement plans. And this is for G and N. There's a slight difference between the two, but it's very close. So for years, it was look at a plan N because the increases are going to be less than a plan G. And at least the last couple of years, that hasn't been the case. But plan N does start lower. So a 10% increase on $120 is not the same as in terms of the dollar amount as something higher of $150. But the point is we had about 10% increases from 2023 to 2024. And it's looking like in 2025, it will at least be that, and it could be more as the average across the country. Before that, we would see, I don't know, threes, fours, fives, maybe seven in terms of those increases as the average, but it's popped up. And the reason is that there are more claims being filed and more expensive claims being filed. So the way that these increases work, it's not just some supplement plan company saying, I want to get rich, so I'm just going to throw my increases as high as possible for my members. It doesn't work like that. Supplement plan rates are determined and set, not, they aren't determined, but they are restricted by your state Department of Insurance. So if I am an insurance company offering supplement plans and I want to do rate increases, I have to submit it to your state Department of Insurance first. They will look at that and I have to justify it. So I have to say, look, this is how much I'm bringing in premium amounts, how much I'm collecting. This is how much I am paying out in terms of the claims that I am having to pay for these people. And then there's going to be a little bit of a buffer, hopefully, where I can cover my overhead costs, like employees and buildings and everything else that goes into running a plan, as well as hopefully profit at the end of that. But that profit number can't be this exorbitant amount of money where I can just make as much as I want. And so what is happening, a big number that we look at is called a loss ratio. And what that loss ratio is, I'm going to pretend like I'm drawing something here, but on the top is the amount of money that I have paid out in claims. And then there's the line. And then on the bottom is how much I have received in premium dollars. Okay. So a loss ratio of less than 100% is ideal for the insurance company. And then a loss ratio above 100% is a problem. And we look at loss ratios a lot when we're trying to determine, okay, what will these increases look like? I have seen companies that have had loss ratios in the 70%. So 70s. They bring in $1 million in premium. They pay out $700,000 in claims. They have $300,000 left over to deal with overhead, hopefully some profit or whatever else is going on there. And they will still give increases on a 75% loss ratio. They aren't these huge increases like we're talking about, but you could see a 3, a 4, a 5% increase with a 70% loss ratio. The problem that we are seeing here with these companies that are giving huge increases is that they are seeing 100, 150. I saw over 200% loss ratio on a specific plan. And so these plans are hemorrhaging money. And what makes it different with a supplement plan, not only is it regulated by the state, but I can't set my supplement plan rates to offset other areas of my company. So if I ever offer a Medicare supplement plan, and I also offer a Medicare Advantage plan, or I also offer dental coverage or employer group plans or ACA plans through the marketplace, I can't use my supplement plan to subsidize those other plans. These supplement plans are working kind of on their own. They have to be self-sufficient in that way. And so with these increases, if you have a plan that's seeing a 200% loss ratio, that's going to be reflected in that plan. So there's been a couple of downstream effects with this. So one, a lot of people are getting their letters saying you're having this huge increase. Two, there are 3 companies that have closed their books. And this was not expected with certain of these companies. So Allstate and Ace. Ace is backed by Chubb, which is one of the biggest insurance companies in the world. Allstate is a familiar name, more so for like home and auto, but they were in the supplement plan space. And they have announced that they're closing their books. And so there are some impacts of what that could mean with closing their books. What that means is that from a supplement plan perspective, let's imagine that I've got this pool of people that are sitting in here. And typically, the older you are, the more expensive you are. And if you are getting up there in years and you're perfectly healthy, don't take this as me saying that that's you. There are exceptions to this. But in general, as we get older, we cost more. And then there's new blood coming into the pool that is less expensive. And the less expensive people tend to hopefully offset the more expensive people. When you close a book, that doesn't mean that your insurance company is going out of business. It doesn't mean that they're getting rid of your plan. It just means that they're not allowing any new people into that plan anymore. And so you've closed off that group of new blood coming in and hopefully less expensive people coming into that plan. And what that means is that when you get these massive increases, you're closing your books so that new blood can't come in there. The people seeing those increases, if they are healthy, they're going to jump that plan. So they're going to go and through underwriting, if they can pass, they're going to jump to a lower cost plan. So now not only have you shut off the new blood coming in, now you've gotten rid of the good risk in that pool and you're left with more expensive individuals within that pool, driving the costs up. And then if you can't pass underwriting or you're not in a state that allows you to switch easily, you have to deal with the brunt of those increases. So that's kind of the applicable problem of what's going on here for those who are seeing these increases. If you live in a state that has unlimited open enrollment, so that would be New York, Massachusetts, Connecticut, you can switch whenever you want. So you can, if you just got a huge increase, just have your agent or your broker, or you can do it yourself, just shop other supplement plans that are lower cost and make that jump. If you live in a state that has a birthday rule, so three states that are being hit really hard right now are California, Nevada, and Illinois. All three of them are birthday states in some form. California and Nevada are good birthday states. I think Illinois' birthday rule is not good, but it is technically a birthday rule state. So if you live in a birthday rule state, then around your birthday, work with your agent or your broker and shop plans that are lower if you just saw one of these major increases. If you didn't see a 30 or a 40 or a 50% increase, I'm not saying like that's good. Just understand that increases are happening all over, and it doesn't hurt to shop around. But if you got a 10% increase, I know it doesn't feel good, but know that it's probably much worse elsewhere. Are the rates then higher for all ages equally in percentage? Okay, so in most states, these Medicare supplement plans are age-based. So if it is an attained age plan, here, I'm going to throw that up, Frank. This is a good question on topic with what we're talking about. If you're in an attained age state, you could potentially see 2 increases a year. The first one is based on your age, and then the second one is based on that plan's annual increase. The plan's annual increase is what we're talking about right now. So that plan's annual increase that happens, and this is not regulated in the same way of those of you who are on an Advantage plan, or if you're on a Part D prescription drug plan, you have your annual enrollment period that is October to December of every year, and then that goes into effect on January 1st. With supplement plans, not all of the insurance companies have their increases for January 1st. So we've just seen a bunch announced for May. I know that some insurance, this is up to the insurance company. Some could be in September, some could be in July. It just kind of depends on the insurance company that you're looking at, that you'll get these announcements. And so you're going to get that annual increase whenever that plan's anniversary date is. And then you could see a second one based on your age. Typically, the age-based increases are not tied to this same, we'll call it the loss ratio. It's just more based off of an age, kind of an age accumulator that they have built into their plans. So a lot of the insurance company that I worked at least, had that age premium boost that was kind of like a flat amount based on whatever the annual increase was. So it wasn't that they were adjusting both as a percentage. It was the annual increase would change as a percentage of the loss ratio, and then the age one would just be a little multiplier, not even multiplier, in addition to what that was. So great question there, Frank. So what are your options? We're going back to, if you are in a birthday state, you can make that switch around your birthday. Some of the states that have garbage birthday rules, sorry, I just think that they're terrible, would be Illinois. So Illinois, you can only do this up to age 75. After age 75, you aren't allowed to switch like this, and you're only allowed to switch within the same insurance company, which doesn't really do us a lot of good if your insurance company is the one that is having the issues and having these increases. Louisiana, you have a terrible birthday rule. It's pretty much the same thing. It doesn't stop at 75, but you can only switch within the same insurance company. And then these insurance companies have affiliates. And I'm going to do my best to explain this as quickly as I can, but Mutual of Omaha is one that's known for this. But so Mutual of Omaha has a bunch of different Mutual of Omaha companies all under the same Mutual of Omaha umbrella. And so if you have a supplement plan with Mutual of Omaha company number 1, there's a different affiliate that is Mutual of Omaha company number 2. And if you have Mutual of Omaha company number 1 supplement plan that has this major increase in Louisiana, you can only switch to Mutual of Omaha company number 1 and whatever supplement plans they have. You can't switch over even to Mutual of Omaha company number 2's supplement plan to find a better rate. So you're stuck within that same insurance company and the same insurance company affiliate. And so if they offer a plan G and a plan N, then you could switch down to a plan N, or maybe that plan number 1 has a supplement plan G book and they've closed it and they have an open book. Like that's theoretically a possibility, but they're just garbage rules. And then Utah follows the same Louisiana one. Utah's went into effect this month. That's where I live, is Utah. And they just did a birthday rule that says you have to stay in the same insurance company. So not a big fan of that, but all of the other states with birthday rules, and I actually have a list up here. I can go through this. Oregon is great. California is great. Idaho is great. Utah is not great. Nevada. So California and Nevada are 2 of the states that we talked about are having problems. It's great. You have a birthday state. Oklahoma, Louisiana is not great. Illinois is not great. Kentucky and Maryland. The other option here would be an anniversary rule. So there's only one state that has an anniversary rule, and that is Missouri. So instead of being around your birthday, it is around the anniversary of when you got that plan. That could be around your birthday if you went on Medicare around your birthday, but it's when you started that plan. There are some states that are starting a birthday rule as of January 1st. So Virginia and Indiana, you're joining the birthday rule states. And then Minnesota on August 1st of 2026. This was supposed to be this last year, but they have postponed it a year to do kind of an economic impact study, is what it's called. But they have an open enrollment period, is what they're suggesting for supplement plans with no underwriting. And that would follow the annual enrollment period from October and go all the way through March 31st. So including the annual enrollment period and the open enrollment period, where you could jump on a supplement plan with no medical underwriting. Then we talked about the open enrollment states of New York, Connecticut, Massachusetts. Washington, you're a special state. If you're already on a supplement plan, you can switch anytime you want. Maine, if you're already on a supplement plan, you can switch anytime you want. You also have that 36-month trial right, which is fantastic. Vermont, it's not a state law, but there are several insurance companies that have open enrollment year-round that you could jump on with. Rhode Island has some other interesting stuff that doesn't really apply here. So just the idea of if you're in any of those states and you're seeing these major increases, work with your agent or your broker and find a plan that is less expensive than what you're seeing with these major increases. What else? If you are on one of those plans like ACE or Allstate, again, if you're in one of these birthday states, you can look at switching. You can look at what your increase would be and write it out if you'd like. Or if you are healthy and you don't want to deal with that risk, then you could look at what it looks like to go through medical underwriting and make that switch. Yes, Clinton, Indiana has a birthday rule starting January 6th of 2026. Let's see, what else have we got going on here? This is going back to the high, kind of the budget of Medicare and these supplement plans. What I find interesting, and at least in the space that I'm in, and I kind of absorb a lot of comments from both Medicare beneficiaries. I get people from insurance companies that reach out pro or against. I have doctors and just the people that I generally work with. I think the problem that I see in the world from our healthcare perspective, because it is messed up, there's a lot of stuff that I don't personally agree with from the healthcare perspective. But I think one thing that I would counsel all of us to avoid is pointing fingers at one bad guy. What I have noticed is there isn't one bad guy in the healthcare space. So if we were to say, hey, if we could just fix the insurance companies, then everything would be okay. That's not the case. So our insurance companies, do we have problems with insurance companies? Yes. Do we have problems with hospitals and their billing practices? Yes. Do we have problems with providers and their offices that are committing fraud? Yes. Do we have problems with the pharmaceutical manufacturers and the PBMs, the pharmacy benefit management companies? Yes. Are there problems within the government where incentives I don't think are entirely where they should be? Yes. And so there isn't one thing that we can point to. And as a general rule, from what I see, is there's usually a small number of bad apples that are causing problems for everybody else. So just something to keep in mind as we go through all of this. $93 a month is assuming that it's a Plan G. And again, Clinton, I don't remember if you're Indiana, then that's a good rate. I just keep an eye out there for sure. All right. There's a couple. If you have questions, throw them in there. I'm happy to answer them. I have some questions from other Plan N. Great. Yeah. Sub $100 is great. I'd have to go back on Indiana to see what our average is there. Here, let me just pull that up real quick. I just have this spreadsheet where I can look at, yeah, the average for Indiana Plan N is a 95. So you're currently still right under that, which is great. There was a question that I had from another video that I thought would be important to bring up here. That is also kind of in the headlines. So I was asked to address the baby boomers all turning 65, and should we contemplate signing up with United Healthcare AARP, considering the company now seems to be in a free fall? So I want to, again, the lawsuit that has been announced through the Wall Street Journal is not something that, from what I can tell, is officially filed, so I can't go read it to understand exactly what's going on. The stock is in a free fall, so let's talk about how this actually impacts you watching rather than just trying to scare everybody. So there is this lawsuit around United Healthcare potentially denying claims that they shouldn't have. And the most direct impact on you right now for seniors who are looking and are in retirement would be that stock price. So if you have ownership of United Health Group stock, and that doesn't necessarily mean that you directly went out and bought it, but it's included in one of your index funds, where maybe that's a mutual fund, maybe that's your 401k. United Health Group is one of the biggest companies in the world, and it's done relatively well financially for a long time. And so your portfolio could be feeling that impact in terms of, like, you could point to it and say, yes, I can feel that. On the side of the claims that they are looking at, if you have an AARP, a United Health Group Advantage plan, and you were experiencing denials, this is something that is going retroactively. So it's not something that they would say, hey, you were impacted by this, we're going to reverse that. And then obviously, if you've had a loved one who has passed away or something since then, again, that's not something that we can bring that back. So my heart goes out to you experiencing this. In terms of choosing them for a supplement plan, supplement plans have nothing to do with the denials. So that's not something that I would look at. The supplement plans are, as we talked about before, it's going to be related to how that supplement plan is performing individually rather than the rest of the company and how that operation is going. With United, I looked at this about a year ago, and I want to say the number was, in New York State, 82% of all New Yorkers are covered by a United healthcare insurance plan, which is wild to me. So United is a behemoth in this space. And yes, the stock price is going down. There are some things that they need to fix, but I don't see them going out of business. I don't see this necessarily impacting those of you on the United plans. One of the rumors around this lawsuit was that it was because United was denying claims they shouldn't have, and then they decided to stop making those denials. And so the investors of United were mad because now their profits weren't going to be where they were. Again, I don't know the validity of this at all. But let's talk about the denials first. I have several videos of this. If you're just joining, I'm Eric. I'm a Medicare nerd. A lot of familiar faces in the chat here. So again, feel free to ask any questions that you may have. But on the denial side, there are several videos of why would an Advantage plan deny claims? And so can we have an open conversation with each other about the idea that there are valid reasons for a denial to happen? And let me give you a couple of those. If you are on a managed care plan, we'll use United because they came up. I'm on a United Advantage plan that does not have out-of-network benefits. And so it's an HMO. I have to stay in network. And then I decide to go out of network. Due to the terms of that plan, if it's not an emergency, that's going to be denied. So that is a valid denial in the context of getting this plan. The second one, and this happens all the time, I had a United Advantage plan. The annual enrollment comes up, the annual enrollment period, and I switched to a different one. And I don't want to target an individual insurance company here, but I'm not on United anymore. I go into my doctor, who I visit all the time. I did not tell my doctor that I have a new insurance card. My doctor bills United, but I'm no longer on United's Advantage plan. I'm covered by a different insurance company. That is going to be denied 100% of the time. That is a valid denial. Okay. The next one would be improper billing codes. What happens with this is that a doctor's office requests something and for a specific reason. And then there are these billing codes that they submit with this prior authorization saying, we would like to do this. Here's our documentation. Here's our reasoning for it. If that billing code is incorrect, that will come back as a denial. Now, this is not me blaming the doctor's office in any way, shape, or form. These codes are insanely complicated, and 0001 and 0002 are almost identical, but there's this little thing that's different in the two of them. And so if the doctor's office is used to just pushing through one, but it doesn't have the documentation for it. So is that a valid denial? I mean, technically it's a valid denial, and there are things that are going on behind the scenes starting in January 2026 and into the future where they're trying to streamline that process to make those better. But those are what I would consider valid denials. If the doctor is trying to perform something and they're billing it under a different code, if you are not covered by that insurance company, period, and then if you're going out of network for non-emergency care. The big thing that I think gets everybody upset would be those that are denied for being considered not medically necessary. And that is something that I think we can all agree on, that if something is medically necessary and it's denied for profits, that's a problem. And I will fight that battle with everybody else. I think it's important that we understand this denial, or at least the justification in the medical necessity process. I actually spoke with an expert on this. I'm hoping that I can bring him onto the channel because he can explain this in even more detail with all the technicalities of it. But there are two major, what I would call, guideline companies that they have these guidelines that are for insurance companies and medical billing offices. And with these guidelines, they are peer reviewed and they are put together by practicing physicians for a course of care for everything, for every possible procedure you can imagine, right? So if one of them that he showed me was the breast reconstruction surgery. And so is a breast reconstruction surgery medically necessary? And then what are the most effective ways to do that? So the first one to understand is interqual. That is these guidelines that United uses, some Blue Cross plans use it. And then most hospitals and most insurance companies also are using what is called the Minimum Care Guidelines, or MCG. And so what happens is that a lot of this is automated. And so they say, hey, we want to go through this course of treatment. The insurance company uses these guidelines and they say, okay, that mode of treatment is not considered the next step in what we would consider the most effective treatment. And of course, that doesn't rub doctors the right way because, like, look, we're just trying to treat our patients the right way and get this handled correctly. And now we're bumping up against these guidelines that are saying no. So that's kind of the process for this. On the insurance company side and on the hospital provider side, we have two different technology platforms. So for the past 40 years, they've been building their technology stacks and they aren't the same. And so that communication, the way it was described to me, is imagine that you've got this 8-lane highway and then it converges into 2 lanes between each other. And then it comes back on the other side and it's different number of lanes. And so this is what they're trying to clean up in 2026. Sorry if I got too complicated for people, but in 2026, they're trying to make the prior authorization entire process more efficient and more effective so that it's happening sooner and that it's more accurate. The total denial rate, and I will show you this. Let me get this for you. I think this is a incredibly important article for everybody to understand where it is and what it is. This happens every year. The Kaiser Family Foundation looks at the Medicare Advantage prior authorization determinations in the entire year. So there are 50 million in 2023. This is published in January. This is this year, and it's 2 years back. So they always put this out 2 years back, kind of like determining your Medicare premiums. So what they do is they look at all of the prior authorizations and then they start to map things out. So we can see that there was a dip in prior authorizations with COVID, and then it's climbed back up. So 2023 had a lot. What I want to get to here is that Medicare Advantage insurers denied on average 6.4% of all prior authorizations. That includes valid reasons and what we would describe as invalid. Maybe they were medically necessary to the doctors, but they were denied. Then of those, 11.7% were appealed. And of the appeals, 81.7% were overturned in some way. So what I get from this is that denials are lower than what the news would tell you. What I have seen people say is it's 33%. It's nowhere near 33%. The people who appeal their denials are very low. So call it 1 in 10 will deny it. Or sorry, will appeal it. Of those that appeal, there's a very high success rate. So if you get a denial on your Advantage plan, have your doctor appeal it. Again, if it's an improper billing code, that's a quick fix. Here, let's go to the one. Here is overall. So there's that 6% overall. Here is the United at 9.1%. So it's not 33%. It is higher than the average. It is not the highest. It's not the lowest. So something to see there. Here's another thing that I think is so important to understand with this. There is the use of prior authorizations in traditional Medicare, something that I think a lot of people don't realize exists. Now, it's limited to certain procedures. So there's certain outpatient hospital services, non-emergency ambulance transport, and durable medical equipment. There were about 400,000 prior authorization requests in 2023, and CMS and traditional Medicare denied 28.8%. So denials do happen on traditional Medicare in those areas that have the prior authorizations. And then of those that were appealed, there was only 6.4% that were appealed. This is 2022, sorry. And then that overturn rate is 28.7%. So on traditional Medicare, of the procedures that require a prior authorization, they deny at a higher rate, fewer people appeal them, and then the odds of getting that appeal overturned are lower than on an Advantage plan. This is in no way, shape, or form me trying to persuade you to get an Advantage plan. It's just the reality of how all of this works. Prior authorizations happen. There are denials that happen. There are valid denials that happen. And then there are those that we would consider not valid denials. Skilled nursing care and the way that that is handled by Advantage plans is something that I personally am not in the most agreement with. Skilled nursing facilities tend to have a higher denial rate in terms of the number of claims and how long they're going to allow you to be in there. So skilled nursing, I think, needs a lot of work. There was a Office of Inspector General study that was done in 2022 that talked about how they looked at a number of claims. I'd have to go back and I have a whole video on it, but they took a couple of hundred claims and they said of those, 13%, not just claims, they took a couple of hundred claims that were denied. And of those, 13% they said would have likely been approved if that person had been on traditional Medicare and not an Advantage plan. So if we were to translate that 13% of denials, it's not 13% of all claims were denied, but 13% of those that were denied should have been approved on traditional Medicare. If we apply that number to the 6.4% of total denials, it means there's a 0.8% improper denial rate. So a 99.2% proper denial rate, which that's not me to judge. This is extrapolating data all over the place, but the concept is that denials are not as crazy as the media would have you believe, but they do happen. Again, I don't want to discredit those who have gone through it. They do happen. It's something that I think we're all trying to fight. Okay, that was my little rant about denials, and somehow that came from United Healthcare's thing. Open to any questions that you might have here. Just going through the comments. Thanks for being here, by the way, on this Memorial Day weekend. I hope that you are able to spend it with your family. It's a beautiful day where I'm at here in Utah. It is gorgeous, and I am going to cut myself off here in about 5 minutes. So I've got 5 minutes here to go through stuff. If you don't have questions, I do have a question that I do want to address for everybody because I've made a video. And so for those of you watching, I would love to know your opinion on this. And here's the question that I got. Where'd you go? I've been watching Dr. Ed Weir on YouTube, and he recommends using Chapter Call Center. Do you have any suggestions on them? So this is something that I do want to address because I've been getting it a lot. I actually made a video on this, and I haven't made it fully public yet because it makes me nervous. Like, I'm on YouTube. I wouldn't want somebody like coming and making a video dedicated to how I look silly or I say things that are crazy. And so I don't want to specifically talk about Dr. Ed Weir for that question. It's the chapter. So what I have noticed is that there are about 12 to 15 what I will describe as senior influencers, and they have a very clear blueprint that I have. They are all doing essentially the exact same thing. So they all come on and they have relatively what I would describe as inflammatory topics that they talk about because that's easy to do. Right now, there's a lot of changes that are happening. And they talk a lot about Social Security. So most of these channels are based on Social Security and finance. So they're talking about the changes in Social Security, and then they bring up Medicare and they refer to Chapter. Chapter has reached out to me, and they also wanted to be a partner on this channel. And so I did some digging. I had a few conversations with them. The way that I am set up is that I have 9 different agency partners throughout the country. And between all 9 of us, we are able to cover all 50 states. And not only are they licensed for all 50 states, but they are very familiar with all 50 states and the Medicare plans and the rules and the hospital systems and what's going on there. So if somebody reaches out to me and I'm not licensed in your state, I would connect you to I just have 9 because I don't want to babysit, and I know them. I've known them for years. I know them by name, and I know that they're going to take care of you the same way that I would take care of you. So my ask of Chapter was, in those states where I don't have people, if somebody reaches out and says, hey, I live in Alaska, can you connect me with an agent that is in Alaska? My ask of of Chapter was, do you have agents in all 50 states? And the answer was no. They are a call center. So they have a call center. Most are in one area of the country, and then they have some remote workers, but they are a call center that helps with Medicare. I have a video all about my feelings, and I've been saying it for 4 years, how I feel about Medicare call centers. Chapter, just for background information, it was co-founded by Vivek Ramaswamy, and also it was backed by the venture capital firm that is owned by Vice President J.D. Vance. This is not me making a political statement for or against either of those individuals. It is my general caution. I do not like when people with political power and affiliations are affiliated in profit-making companies that are connected to senior benefits, specifically Medicare and Social Security. That's just me personally. You may feel differently, and that's okay. I am not a fan of government or politically powerful individuals having profit-generating companies tied to senior benefit programs. Anyway, I think that there are conflicts there in general, and it's not just those two happen to be affiliated with the Republican Party. They have a member of their board that is a member of the Democrat Party. So again, it's not a party thing. It's just in general from a government and profit-making business. Chapter has raised $185 million through venture capital. $185 million is a lot of money to pay back. So then that conversation with them and me, I had told them, hey, if you aren't going to offer me individual people within a state, because that's not logistically super realistic of anybody to ask, then I'm just going to stick with my partners, because I think that we offer just as much, if not more, than what a call center could offer. And the response back to me was, okay, we respect that decision, but we firmly believe that we will close at a higher rate than your partners, and we will pay you more than your partners. And then I have the email, again, it's in a video that isn't public quite yet. In the email, they talk about one of their partners who made $450,000 in commission during the last annual enrollment period. So in a 7.5-week period, their Medicare referrals generated $450,000 in commissions for them. And I'm all for people making all the money in the world that they want, as long as it is done in an ethical manner. What gives me a red flag is stating that their close rate is going to be higher than my partners. Anybody who has reached out to me, I think you can attest. If there's anyone in the comments who has reached out for help from me, please let me know if you feel differently. But I'm about as hands-off as it comes. If you download something from my website, so we've got Social Security taxability calculators, we've got long-term Medicare cost calculators with the different plans over 20 years. We have all these free downloads that you can get. If you download any of them, I do not harass you. I do not bombard you. I send you what you downloaded, and then if you want our help, you let me know. I do not want to pester you with anything. You aren't going to be put into some sort of a drip campaign where you're going to get emails every week or every month. The only scheduled emails that anybody get from me are if you've signed up to receive the monthly newsletter, and I send one message a month through the newsletter that is just goofy things. There's my goofy stories of what's going on in my life. There's a book recommendation, and then just kind of hot topics of what's going on in the Medicare and Social Security space. So if somebody says, hey, we're going to close at a higher rate than what your partners are, and all my partners feel the same way, that sends a red flag up to me of, okay, are you going to be more aggressive than what we are comfortable with? Because seniors are crushed by marketing. I hate it. I went through it with my parents. I go through it with my in-laws. I go through it with my friends that are seniors. And I do not want to add to the problem of marketing, of your phone blowing up, of your emails, of your text messages, of all of this stuff, trying to persuade you to get on some sort of a Medicare plan. That's just not what I feel is great. So going back to the original question, it's not just Dr. Ed Weir. There's 12 to 15 of these influencers that are all pointing to Chapter. We saw this with the crypto scams. We saw this with the Honey. There's a Honey plugin that you could do in your browser. We saw this with NFTs. I get a little bit nervous when there is all of the major influencers in a certain space pointing to the same thing. Now, I genuinely hope that Chapter is doing good things, and I highly encourage you to go look at them. I'm not saying this so that you use me. I have several channels, and in almost every video I say, go use one of my competitors if you don't want to use me. We are not the only good guys in this space. There are a lot of great brokers and agents out there. Go use them. Just make sure that you're looking into them and what they are. If it's a call center and you call in and you get John Doe as the person who's going to help you get on a plan, and then you call back a year later and that's not John Doe who's going to help you, it's just a call center that's been passed around, that's not how I would want to be taken care of. And so that's not the service that we offer. We offer something different. So And then there are other great agencies that offer something different too. So if you're looking for Medicare advice on YouTube, I'm glad that you're here. There are great channels other than me out there that are doing a great job, and they are Medicare agents. They are licensed and they are trained and they are able to talk about Medicare and help you with that rather than not being licensed to talk about it and then pointing you to another service. So that's my 2 cents on that. All right, I'm going to look through this really quick here. Thank you. I appreciate you so much. I agree on the call center thing. Um, I'm just going through these comments here before I jump off. Get a local agent, Corinne, for sure. Again, that's me saying like we don't offer local agents everywhere. So I'm just going to pull this up. Get a local agent, right? This would be something that it was like, hey, that's anti-Eric in a way. I'm all for it. If you have somebody that is in your area and you prefer to sit down and meet with them face to face, do it. That is fantastic. I can't offer that to everybody. Again, I have my 9 partners across the country. They do Zoom meetings. So if you would like to see them with their face, it's not all phone calls. You're not calling into some call center and then being passed around all over the place. They do Zoom meetings. But yeah, I don't have partners who are physically located in all 50 states, but we are licensed and familiar and able to help people in all 50 states. And I'll name the channels like the Giardini team. They have some great videos. Cameron goes into a lot of depth on his videos. The Stephanie Apt, I think she has some fantastic videos. I don't know her personally, but I like her videos. Medicare School, I actually got to meet Marvin a couple of months ago. Super cordial, great guy to talk to at Medicare School. He's got the biggest channel in the Medicare specific space. I think those are all fantastic channels to watch and reach out to them for help. Like again, there's so many people, 11,000 people a day turn 65. There's plenty of people to help out there. So again, this is not me trying to bash any one individual company or organization. Just be careful with the influencer guidance out there. That's all. Okay. Thank you. I'll show. So we do have AWS. I don't know your real name, and you don't have to throw it in the comments, but in your emails, thank you for reaching out. I answer all of the emails. Any email that comes through our contact form goes to me. It is you will interact with me. Clinton, you were Stephanie Apt. That's fantastic. I think you tell me otherwise, maybe offline if you feel differently, but I think they do a really good job. Agree, Corinne. Just follow up to yours. I agree 100%. Okay, I'm going to jump off. I'm already a little bit late, but thank you for spending time with me. If you have any questions, if you have any concerns, you can always send me an email at eric@theretirementnerds.com. That is my email. It's not some service email. It's not going to anybody except for me. Theretirementnerds.com is our website if you want to go download any of those free things that I talked about with spreadsheets or guides or all kinds of fun stuff. So thank you for spending time with me. I appreciate you, and I will see you in the next video.